just work out how to use this before I get started. So hi everyone, I'm Julie Bardsley, Tobacco Dependency Lead at North Tees and Hartlepool NHS Trust, and I just want to kind of give you a snapshot of how quality improvement processes have helped us develop as a trust. So really I started, as everyone would in the beginning of the service, not really fully understanding how the full quality improvement process works. So it's been about learning that process along with so many other systems within the tobacco dependency service. So a great motivator for that was the support nationally through the British Thoracic Society, and that really got us started with our first project that's not on here, but it did help us increase referrals from 23 patients seen in the first month to over 270, 219. The team get quite competitive. Can we make 300 this month? So that was a really successful project. And then we've done like a qualitative project on implementing vapes at the Trust, which has had really positive feedback as well. So this is a couple of the highlights of one for maternity services, because we work across both, and then also a current project that we're just starting to get going with. So this quality improvement project was about setting up a service to kind of bridge gaps in provision across our trust footprint, can't get my words out. And it was because of the differences in community provision across our local areas. So at the beginning of the project, we had identified that maternity service users were receiving an inequity of smoking cessation support at Hartlepool when compared to provision by neighbouring local authorities. So as a team, we prioritised levelling up the services, and we set up from scratch a weekly smoke-free pregnancy clinic. At that time, we were a very brand new service, not fully recruited, and kind of tried to manage the best that we could with the capacity that we had. So we worked with all the relevant people in the trust to kind of set up provision to NRT, having clinics, the whole lot, having systems. There was no systems to record, provide and support. So that was all done. And it allowed women for the first time the opportunity to have access to nicotine replacement therapy in quite a few years, alongside the behavioural support to prompt successful quits. So this provision, as I say, brought new opportunities for our maternity service users. It did have its limitations due to the capacity of our team to be flexible around tailoring lots of home visits for the pregnant women and families, or appointments on days and times that suited service users. So in the spirit of kind of coming together as a trust and collaborative working, we looked at how we could share skills and cascade skills and use the people, their knowledge on the shop floor really, to provide provision in-house. So it was a case of our services. Some of the advisors, Kirsty and Tina, were really good in supporting with myself and Natalie, the trainer, linking with the quality improvement leads and the Hartlepool midwifery assistants. So we managed to develop between us a more flexible in-house midwifery-led quit programme for Hartlepool, obviously with the aim of increasing successful quits. And it was about building a truly in-house model provided by the midwifery assistants, who are seeing your pregnant women and families for all their other appointments and using the MEC approach. So the rationale would be increasing the flexibility in the in-house offer would increase rates, improve birth outcomes, reduce financial burden on the NHS and align with the NHS long-term plan, and improve long-term health and well-being at the heart of it. So the project summary, Tobacco Dependency Services and Midwifery Assistants shared valuable learning from the weekly smoke-free pregnancy clinics. Frequent meetings included training, learning systems, support to access nicotine replacement therapy, electronic vouchers, the incentive scheme came into place, refreshing on behavioural support techniques and documentation systems. And then the midwifery assistants at Hartlepool did a lot of shadowing of clinics that Kirsty and Tina were providing over at Hartlepool site. And then the midwifery assistants soon became confident to kind of provide that support in-house. So the project was really successful. It proved extremely successful with a 500% increase in 12-week quit rate between April and August 23. And the success has continued to build momentum over the last year, seeing 41 women quit smoking in Hartlepool alone. So the next steps of what we're going to do is to explore any support that's required across the other midwifery assistant teams that are covered by our trust, and share the learning from the model that's been approached over at Hartlepool. So that's the maternity project. A current one that we're working on is to really increase the involvement of the clinical frontline staff alongside the tobacco dependency service. So it's about us all working together for the same goal. So what we've identified from the data is that around 84 to 94% of inpatients are being offered and given NRT when it's a collective aim through the frontline clinical ward staff and the tobacco dependency treatment service. But when you take that down to a level of what's happening when they come through the front doors within 2 hours of admission and what are the frontline clinical ward staff doing, the increase, we really need to increase in the area of initiation of NRT. So that all comes into play with your very brief advice and actually following through the actions rather than just saying the saying, it's doing the doing. So with quality improvement, you can set yourself aims. It's trying to make them realistic, and you can always look at that and adjust it if you think you've set your standards too high, so to speak, because we know obviously once you get down to the nitty-gritty, it's not always easy as you expect it to be. So what we aimed for was to increase the number of ward staff providing an RT from 32% to 60% by March 25. That date I've moved along as well. So the rationale is the same as what we all understand. It's improve your patient experience, it supports your smoke-free policy. I'm practising to the preach here, Anna, so preaching to the practice. Can't get my words out today, can I? Sorry. So reducing environmental waste posed by littering of cigarette stubs, reducing your health inequalities and so on. I don't need to say those things. So the summary of the project progress today is it's in its infancy, whereby we're linking with stakeholders, identifying the right people to work and join the project. Data collection has been arranged. We've made resources that are more kind of user-friendly for your frontline clinical ward staff, adopting the themes that have been used regionally, so frontline staff quick guide bundles. We're focusing on the EAU area. I'll speed up, I'm being told to stop. And these meetings are really just looking at sharing data, linking with your stakeholders, and looking how we can get past any barriers. And that's just like a little shot of the simplified VBA pens, NRT decision aid and prescribing prompts that we've developed for the Trust. And then just a quick sum up really, it's about sharing for others that quality improvement has proven to be a valuable tool in helping our service to test and navigate change ideas when we have a problem identified with a clear aim in mind. Learn from your experiences. We're all going to make mistakes and you've got to learn from them. It doesn't necessarily go to plan and that's okay. Advise good planning, involve your QI leads, you'll have them, involve multiple staff groups, don't take it all on yourself. Share responsibilities, patience and resilience, we all need that, and I'd highly recommend using that to other services. So,